And over to you, Sunita. You have a challenging task of summing up on 3 situations. You have Hydrops, DMED, DMDs, and Intra Tarsals.
Thank you, Dr. Vanity, for giving the opportunity. I'll first deal with DMD. So the procedure of choice for managing DMD attachment is desmetopexy. And we mainly use 3 gases for tamponading. One is air, which is 100% taken through the microfilter, C3F8 gas, and SF6. So the key point to achieving it's a simple process, but to achieve a best success in any procedure, it is important in desmetopexy to identify the correct plane and the configuration of the DM, and towards the end of the surgery, achieve a good air pressure tamper. These 2 things, if we are able to achieve, we will get best outcomes in desmetopexy. So ensuring that the cannula or the needle should be beneath the plane of the DM, this is important because cornea will be hazy. And one important key point is to understand which is the relative area of corneal transparency, which is much better than the rest, because this is the point which determines where we are going to enter and inject the air, and we are going to be below the plane of the Descemet's membrane. So summarizing the salient steps of the surgery, we need to identify the location of the side port entry for air injection. Peripheral site chosen is where the DM is attached, or at least its closest proximity to the stroma. Some bit of aqueous release can be done to accommodate a tight airfill because we need to create some space if there's already some air bubble already from a failed previous desmetopexy. And followed by, we should maintain a supine posture just like the way we do for DSEC and DMED for about half an hour or so. Thereafter, if there's a complete airfill, we can do a guarded air release at the, later on sit lamp. So this is a very simple procedure, but these 2 caveats are important to achieve the maximum outcomes. The surgical technique can also vary by, instead of making a side port, we can also do it with a 26 or 29 gauge needle. Again, achieving a complete anterior chamber airfill and for at least 30 to 45 minutes, followed by supine positioning. This is almost absolutely important for all the cases, and thereafter doing a controlled air release as planned. So with this technique, this is consistently the technique which is followed, and this is one case showing a complete resolution on the same day after desmetopexy, and this is a case where there was near total Descemet's membrane detachment, and following desmetopexy, we have a good outcome on the same day of the surgery. Now, there can be situations where DMD has occurred after phacoemulsification or any surgery, and there is a time lag between the time when you see this. This was a case of failed prior desmetopexy at 1 week, and then we saw the patient at 6 weeks with a taut DM. Now, routine procedure of air desmetopexy will not work because DM is taut over here, so there's something more to be done here. Such kind of situations will require a relaxing incision in the Descemet's membrane to handle the taut DM. So we achieve a tight airfill in the anterior chamber and then make relaxing cut through the DM through the anterior corneal surface. Something like with the venting incision, what we do for DSEC we used to do in the past, something like that has to be done. So we remove the epithelium on the top because we don't want epithelial ingrowth into the interface, and we inject tight airfill, and thereafter we ensure that most of the epithelium is clear, and then followed by a venting incision which is oblique, which will be placed obliquely towards the pupillary center, and thereafter followed by a little bit of air release, and ensure again that we have a tight airfill at the conclusion of the surgery. In between the place where we made the venting incision, we should ensure we can use a Sinski to remove the traces of interface fluid which might be there. So we have created a nick, we have created a kind of a relaxing incision on the Descemet's membrane through the anterior surface. And since we want a complete airfill at the conclusion of the surgery, in this case we have taken a suture to maintain a tight tampon. This is the image on the day 1 and day 3 with the settled Descemet's membrane in the taut DM and patient vision recovered to 20/30. So there could be another way of managing such cases would be by using C3F8 because you need a longer tampona. So something similar for taut DM, another option instead of the previous method which was demonstrated. This is again something which works for taut DM, and this is again a case of taut DM desmetopexy, and we have a good outcome with C3F8 also in these cases. Acute hydrops is managed in a similar way, but I'll show 2 techniques in different scenarios. This is a case of keratoconus. Now, there are several ways of managing keratoconus, but the technique which I favor is by using compression sutures. This is only for grade 2 and grade 3 hydrops where it is more than 5 millimeters. For any cases which are grade 1, it doesn't require. So we place sutures, partial thickness. These are not full thickness passing through the Descemet's membrane. These are partial thickness within the stroma to achieve a compression effect. In the center part of the cornea, we take an infinity suture so that it is like an overlay and not passing through the stroma to avoid scarring. And subsequently, towards the end of the surgery, we can see the result intraoperatively itself and place a bandaged contact lens. The same technique is also used for hydrops in pellucid. In pellucid, because the tear is in the concentric region, we have to apply the sutures radial to the site of the tear. And this is the way it is done, and we see a very good outcome even on the day one. And this, in pellucid, it is sort of a refractive procedure because it helps in, you need not remove the sutures and you get a good outcome after the surgery in the post-op. And even with sutures, you can continue to place them and achieve a good refractive outcome as well. Supratarsal injection generally is reserved for cases of shield ulcer, not for routine grade 1, grade 2, they may just do away well with scraping along with the BCL application, but for something which has got a tense plaque might require. And this is one case where supratarsal steroid injection was used for managing a shield ulcer. So evert the eyelid and with a 26 or a 29 gauge needle, either triamcinolone or dexamethasone, or some people have also tried hydrocortisone, can be given in the supratarsal space to deal with recalcitrant or grade 3 shield ulcers. Not a practice which I prefer, but I know of people who would like to give it for recalcitrant cases, is given in the same way. You can give other injections also which are required as a depot, essentially by the same technique, by everting the eyelid and giving with a 26 or a 29 gauge needle. Thank you for your patient listening. If there are any questions, I can handle that now.
Thank you, Sunita. And as Dr. Radhika is setting up for her talk, any questions from the floor for Dr. Sunita?
Sorry? No. Only for the grade 3 large hydrops. For routine, which are like grade 1, they resolve very well, beautifully with they're self-limiting. So they don't require. Only for the grade 2 and grade 3 is something which will require sutures for a quick resolution.